So just some welcome and housekeeping. We will be recording the session, and in answer to Kath Barrow's query, yes, the session has been recorded. We will send out a link to the slides. This will be being made public, so it's really helpful if you turn off your camera if you don't want to be on screen at any point. We have a real mixed audience on the call, including pharmacists, clinicians, sustainability leads, policy leads, management and researchers. So we hope that there will be something for everyone. There's been huge interest, and as I said already, thank you so much for coming along. Because there's so many people, we might expect some technical issues. So please turn off your camera and microphone if you're not presenting. And also please do use the chat function to ask your questions. In other events that we've had, there's been so much value in terms of people asking questions in the chat, answering questions, putting in their expertise and their lessons and so on. And that's been where the real sharing and learning has taken place, as well as in the presentations. I think that's probably it for the housekeeping. Just moving on to the agenda. So very briefly, oh, sorry, a bit of echo. If everybody could put themselves on mute, that would be great. So very briefly, the price of admission to this is you have to listen to me talking for a few minutes about what the AHSN network is. Then we'll move into the real meat of the session. We'll have some of the policy context from Sarah Ouanhnon. We'll have an overview of the Sentinel Programme from Dr. Michael Crooks. We'll hear from Dr. Aarti Bansal on her work as a GP around asthma care. And then there'll be an opportunity for Q&A. If you could put your questions in the chat, I will keep a note of them as they come through so that we can try and answer them towards the end. If we don't get to answer them, we will do our best to answer them after the event in a post-event communication. And then we will close. So just moving on then to the Academic Health Science Networks, which you may not have heard of. So we were set up in 2013-14, and we have two main objectives. We support the innovation pipeline, so we help innovators develop their products and signpost them to the right place. And we promote the faster and wider spread of innovation into the NHS. And we do this to improve patient outcomes and create local economic growth. So each AHSN is embedded in its regional health and care community, as well as being part of the national AHSN network. And the AHSN network is a unique collaborative of expertise and experience. We share learning regionally and nationally. We pool intelligence across the 15 AHSNs to develop programmes around health and care needs. And we offer benefits from a pipeline of emerging and proving solutions from around the country. We know that getting to net zero can't be done through incremental change, although that does play its part, obviously. We need to do things differently, and this is where the AHSNs operate. We're the key interface between innovators from industry and academia and frontline NHS to support improvement and innovation adoption. And what we do makes a difference. So we save lives. Our work on atrial fibrillation, AF, meant that almost 12,000 strokes were avoided and more than 2,900 lives were saved. We saved money. So the AF work saved the NHS £158 million and social care £105 million. We promote economic growth. So in 2021 alone, our work with innovators and industry has leveraged £462 million into our local economies. And we created 700 jobs and safeguarded a further 762. And we help people and their families. So in 2021, 258 patients benefited from our national spread programmes and a further 230,000 from our support for accelerated access collaborative programmes. So our national programmes included Focus ADHD, which is about earlier diagnosis of ADHD for children. So it supported over 2,000 children to receive objective ADHD assessments, speeding up their time to diagnosis and making a significant difference to their lives and that of their families. And this is genuinely only a small proportion of our work and our impact. This slide only shows programmes where we all work together on the same thing, which is usually less than half of each AHSN's work. We work locally and we collaborate widely, and we're successful because we're adaptive and flexible. And we're funded by NHS England and NHS Improvement, along with others, to support specific innovations. And this year and next year, 22-23, we're supporting specific innovations around asthma. So we're supporting systems to improve pathways to enable early identification and appropriate referral of people with uncontrolled asthma. So asthma biologics allow better treatment for these patients, and improving disease control also reduces unnecessary short-acting beta agonists, SABA inhaler. So those are called SABAs. You will know this better than me. So it reduces SABA inhaler prescribing and therefore carbon emissions. So we did a scoping report and a benchmarking exercise that highlighted barriers and challenges in the pathway, and we've developed some resources to address these challenges and barriers. And you can see there the link that if you hover over, you can get to the toolkit to access those materials. And then the second product we're supporting is FeNO, that's fractional exhaled nitric oxide. It's a breathing test looking at airway inflammation. And FeNO testing enables diagnostics and monitoring of asthma. So all 15 AHSNs are working with local project teams to sustainably embed FeNO testing into primary care asthma pathways. And again, that contributes to the net zero agenda by reducing unnecessary use of inhalers. And you can find more information on your local AHSN's website. So because we make things happen, we change how healthcare is delivered, and we're supporting our NHS colleagues to change how they work. And as a side benefit, this is also benefiting the environment. So as an example, we worked with trusts in England to roll out evidence-based placental growth factor diagnostic tests. And these rule out preeclampsia in pregnant women and means that only those with the condition need to stay in hospital. And that reduces the number of bed days and other associated consumables, which all impact on carbon emissions. And we estimate that we saved over 1,000 tonnes of CO2 by implementing this in England. And we've been supporting the rollout of virtual wards and virtual monitoring devices. And these innovations mean that people can be monitored from the comfort of their own home, and that using special kit that takes readings. It looks in your eyes, it looks in your ears, it takes your temperature and blood pressure and so on. And it sends the results back to the clinician for review and for appropriate treatment. This reduces the need for face-to-face meetings, and it reduces the need for travel requirements. We also support innovations that reduce the amount of healthcare people consume. So, for example, health coaching identifies the people with complex multimorbidities who are at risk of being high users of healthcare, and health coaching enables patients to manage their own conditions better, and that then reduces trips to GP, hospitals and other clinical settings, as well as reducing the amount of medication consumed. So the programmes I've just mentioned all support environmental sustainability as a side benefit of the implementation we've delivered. Because we support innovation from idea to uptake, we can also identify and support innovations that have a direct impact on the environment. So as an example, the multicath trial, that's looking at whether or not you can clean and reuse plastic catheters in a safe way. So being able to reuse PVC catheters would reduce waste. Currently over 100 million catheters are thrown away every year in the UK. We're also supporting work around the development of reusable PPE, working with Department of Health and NHS England colleagues. And through our accelerators and support for programmes like SBRI, we're working to identify, that's a small business research initiative. We're working to identify potential innovations that will impact and support them to become market ready so that they can be spread across England. And we work with industry and innovator partners to develop and test new tools and pathways that, for example, reduce emissions from asthma inhalers, and you'll hear more about that later. And we make sure that we signal the importance of this agenda to industry to stimulate the development of innovation with an environmental sustainability focus. And we support innovators to understand the impact of their innovations in terms of the environment. We work with them to calculate and reduce the harm done to the environment, and we're building this assessment to be part of our business as usual activity. So to summarise, our activity falls into four main areas. We support innovations that directly reduce the environmental harm that the NHS does in delivering healthcare. We support innovations that transform pathways and have the side benefits of reducing emissions. Digital is an example. We support the supply chain to be greener through advice and support. And we improve understanding of what environmental sustainability in healthcare can look like, changing culture about services and how they can be delivered. And this event is an example of how we do that. It's just one of the ways that we do that. So that was it from me. I can see in the chat that there is some issues with the slides. I think that is probably due to the large amount of people we've got on the chat. So there are some hints and tips from people saying that, you know, if you turn off the incoming video and so on in the chat, which might help. My apologies if they don't, but we will be sending out the recording after the event. So I'm going to ask Josh to take back control and hand over to Sarah Ouanhnon.
Can everyone hear me okay? Yeah, okay. I'll assume yes, perfect. Great. So hi everyone, I'm Sarah Ouanhnon. I'm a senior net zero delivery lead in the Green NHS team at NHS and NHS Improvement, and I am responsible for our work on medicines, including inhalers. Sorry, can I ask everyone to be on mute? Thank you.
Just bear with.
So let's start with the beginning. Why is it important to have a net zero health service? Today, climate change poses a major threat to our health and also to our ability to deliver healthcare. This change is already happening. It's even accelerating, and we know it's having direct and immediate impact on the health of the population and on the NHS. When we speak about climate change, we speak about more intense storms, floods, more frequent heat waves, and the spread of infectious disease. And all of this threatens all the health gains that we've made in the past few years. Quite a depressing picture, but there is good news. And the good news is that by acting on climate change, we can not only mitigate those adverse impacts, but we can also actually improve public health. And on this slide, you have a few examples of the several thousands of lives that could be saved every year from, for example, improved air quality, a more physically active population, also healthier diet. If we reach the UK's commitment to the Paris Climate Change Agreement. The mission of the NHS is to save lives, and this is why the NHS is also responsible to mitigate its own impact on climate change and adapt to climate change. This is the reason why in 2020, the NHS has made a public commitment to reach net zero carbon. There's been extensive analytical work and modeling to make sure that this commitment was as ambitious as it could be, because this is an emergency, but also realistic and achievable. And this is why we have committed to 2 milestones. One for 2040 to reach to net zero on these emissions that are directly in our control. So we're speaking, for example, the emissions that happen on NHS sites, the emissions linked to the electricity we use, the waste we generate. And for these, we're expecting an 80% reduction compared to baseline in the next 10 years. We've also set a slightly longer deadline for the emissions we don't have a direct control over, but that we can influence. So those emissions are mostly happening in our supply chain, but not only. It also covers, for example, staff commute or patient travel to NHS facilities. For these emissions that we call our NHS Carbon Footprint Plus, we have committed to reaching net zero by 2045 with an 80% reduction in the next 15 years. So on this chart, you can see how the emissions
Sorry to butt in. The slides are not presented on the screen. We're not seeing any of your slides.
I can see them.
I can see.
Okay, sorry. I will leave and come back.
We can see that. Okay.
Sorry, I'll make sure I'll explain also what's on the slide, hopefully, if there are a problem with the presentation. So basically, I'm presenting a diagram that shows how the NHS carbon footprint split across different categories. So when we speak about inhalers, we speak about this NHS carbon footprint, so the emissions that we can directly control. And that's because most of the emissions from inhalers happen at the point of use of the inhaler. So they represent 3% of the overall NHS carbon footprint. So it's quite an important percentage for one single medicine. And these emissions don't come from the actual medicine in the inhaler. They come from the propellant, so the gas that is used in a specific type of inhaler, the metered dose inhalers, to deliver the medicine to the lung. So sometimes these inhalers are called MDIs or puffers. They have different names, but they're the aerosol-based inhalers. And in this program, if we have decided to focus on inhaler, it's not just because of the carbon footprint. I really like this phrase from Dr. Alex Wilkinson and Professor Ashley Woodcock. They say it's a green challenge and it's a golden opportunity. Because we know that currently patients with respiratory conditions have poor disease control, poor outcome, which leads to avoidable exacerbations and also preventable death. We know that in the UK, there is over-reliance on the reliever inhalers as opposed to the preventer ones, which is well known to be linked to poor outcomes. And we know that inhalers are not necessarily used in the right way, so patients haven't been properly trained on the technique to use their inhalers, which means that the drug is not delivered to the lungs the way it should be. So I leave Michael and Aarti to explain more about this, but my point is we have a great opportunity with this work to improve patient outcome and reduce carbon emission at the same time by optimizing the selection, the use, and the disposal of inhalers. So we've been working with the National Inhaler Working Group, which is a group of experts with representatives from patient organizations, but also primary care, secondary care, doctors, pharmacists, nurses. And we have defined our policy around 4 levers. The first lever is around collaborating with the pharma industry to encourage the development and the use of lower carbon propellants. This is very important because some patients will always need MDIs, and so we need to make sure that those remaining MDIs have a lower carbon impact. However, we know that those new propellants are still in development. There's still the usual trials phase and then regulatory approval. So those new inhalers won't be to the market until at best 2025, 2027. So we have to act while we wait for this. And this is why it's very important to act on what we have already available. And this is our second lever, which is optimizing inhaler choice now, supporting patients and clinicians to select the inhaler that's the right inhaler for the patient, always in a shared decision-making process, and always as part of a disease management review. So it's not like a blunt change, it's really a conversation and a discussion. And either consider lower carbon alternatives, so moving completely away from MDIs, for example, using dry powder inhalers or using soft mist inhalers, which have, just to give you an idea, most of them have like below 2 kilograms of CO2 equivalent per inhaler, as compared to some MDIs, which can go up to 28 kilograms. So it's really a massive difference. But if that's not right, we can also move from a lower carbon MDI in some cases. So there's a few options. And when we speak about selecting the right inhaler for the patient, it's again about insisting on the importance of the preventer inhaler and not only rely on the reliever inhaler. Once the right inhaler is selected, it is important to ensure that the patient knows how to use the inhaler and making sure that the medicine gets to the lung in an optimal way. And finally, and I'll come back to that, it's important to make sure that inhalers are disposed in a greenest possible way. So to support this policy, we have developed 4 new indicators in the Investment and Impact Fund scheme. It's known as the IIF, and it's an incentive scheme that targets primary care network. The idea of this scheme and of these 4 indicators is to fund the clinical time that is required to make this change in an appropriate way as part of a consultation and as part of a disease management review. So at the top, you can see the first 2 indicators are really focusing on selecting the lowest carbon possible alternative for inhalers. So for non-salbutamol inhalers, dry powder inhalers and soft mist inhalers for patients who are over 12-year-old, and this is an indicator that is focused on adults. And for all patients on salbutamol inhaler to consider potential lower carbon alternatives, including MDI. The two other indicators at the bottom are about really implementing those best practice around prescribing inhaled corticosteroids and rely less on the reliever like the SABA inhalers that are the reliever inhalers I was speaking about. So the first two indicators have been posed during the booster campaign, but they're restarting in April, and the two bottom indicators are also starting in April. We've also been working on the pharmacy quality scheme, which is an incentive scheme for pharmacists, because pharmacists have a key role to play on improving the use of inhalers. So the first two indicators focus on optimizing the actual use by undertaking inhaler technique check, and also by ensuring that patients have personalized asthma plans and that children are using a spacer, and I've seen comments in the chat. So really ensuring that children use a spacer when they use an MDI inhaler. The two indicators at the bottom focus on the disposal aspect of the inhalers to ensure that staff have had proper training and that they help increase awareness among patients of the importance of bringing the inhaler back to pharmacy. So we've been working with a lot of partners to develop resources to support this policy. And you can see on this slide, there's a lot of them. So my message here is really, if you want to keep up to date on the best and the latest resources to support inhaler policy, really the best thing to do is to register on the Greener NHS workspace on Future NHS. I've put the link on the next slide. And this is where we constantly update as new resources become available, and we signpost to the most really practical one that you can use immediately. So on the healthcare professional side, I wanted to focus on a couple of resources that really summarize the information available around inhaler. The first one is this Greener Practice Guide on inhaler on the left. We've worked with the National Inhaler Working Group to develop this guide with Greener Practice. It's also been endorsed by Asthma UK and the British Lung Foundation. And I'm sure Aarti will tell you much more about it, but it's really a short and simple guide with key messages on how really to optimize the use of inhalers. There's also a quality improvement toolkit that's currently in development and that will really help primary care practice to implement practical projects on how to make that change happen. For those who want a bit more detail around the carbon footprint of inhalers and understanding a bit more of the numbers that are behind this, we've worked with Prescribe, who have produced a data table as well as a very comprehensive briefing document on inhalers, and they've also developed like a number of tools for people who want to look at possible change. And so I mentioned the Future NHS space where we will post new resources as they become available. For the patients, we are also in the process of developing new resources, but there's already a wealth of resource on the Asthma UK website. So there's a number of videos on how to use inhaler properly, like what's the right technique for the right inhalers. And there's also information on why and how inhaler might have been changed. Oops, I think someone took control. Okay. So, sorry, on the patient resources, yeah, more explanation on why inhaler might be changed to get lower carbon alternative. So finally, I will conclude this presentation on disposal. First of all, it's not always obvious to tell when an inhaler is empty, and I guess that's the first problem. Some studies show that patients keep using an empty inhaler, which is not great for disease control, obviously. And also the opposite happens where some patients discard an inhaler that still has medicine in it. This is another advantage of dry powder inhalers. Most of them have a dose counter directly on the inhaler, which tells the patient how many doses are left in the inhaler. For most of the MDIs, it's a bit more tricky. And on the right-hand side, I've just shown this study that looked at how maybe we can link the weight of the canister with what's left in it, but that really doesn't work for all MDIs, so this is not the perfect solution either. So whether the inhaler is empty or not, it's very important to dispose in the inhaler correctly, because there is always some propellant left in the canister. So even if the medicine is fully finished, there will be some of the propellant gas left in the canister. And if the inhaler goes to landfill, the propellant will be freed from the canister and released directly into the atmosphere. If the inhaler is brought back to the pharmacy, the inhaler will go to incineration, and this way the propellant won't be liberated in the atmosphere. So there is more work to do, because ideally we would want to recycle the inhalers rather than incinerate them, but it is still the best option we have at the moment. And some pharma companies have been working on trying out some schemes for like a better recycling of inhalers. But the problem is the same, and the main point is the same, is we need to raise awareness among patients and tell them that inhalers can't go into their domestic bin, can't go into the normal bin, can't go even in the recycling bin. It has to go back to pharmacy for better disposal. So I really wanted to finish on this nice picture, which is from a pharmacy in Halifax. And you can see they've done this display to raise awareness and encourage patients to return their inhaler. So this is one of the examples that we can see everywhere really in the country, not just in pharmacies, but in primary care practice, also in secondary care, where we can see that when the use of inhaler is optimized, it improves patient outcomes and it also reduces carbon emission. Thank you.
Thank you, Sarah. Josh, can I ask you to take back control of the slides in the best political way, and pass over to Michael. Thank you, Michael.
Thank you very much. Let me just take control of the slides, and we'll let Teams think about that for a second. And I think that has now worked. So thank you very much for inviting me to come and talk today. And thank you to the 318, I think, who are currently logged in and listening to presentations. So I'm Michael Crooks. I'm a senior clinical lecturer and consultant in respiratory medicine based at Hull York Medical School. And today I've been given a quite specific task of talking about a quality improvement programme that we developed in Hull and East Yorkshire called the Sentinel Project. So over the next 15 minutes or so, I'm going to take you through what the Sentinel project is, how it was developed, and the changes in practice that we've observed so far. And then I'm going to focus on Sentinel Plus, which is a quality improvement framework that is now available to all primary care organisations around the country. The Sentinel project was developed and continues to be supported through a joint working agreement between Hull University Teaching Hospitals, NHS Trust and AstraZeneca, and really is working to deliver improved asthma care across and on behalf of both NHS Hull and NHS East Riding CCGs. Sentinel Plus is owned by the University of Hull and developed by the Sentinel project team in collaboration with AZ. And that's available to primary care organisations through a donation of goods and services agreement. These are my disclosures. And so today we've already heard about the impact of asthma and its treatment on the environment. And you've also heard about how important inhaler selection is to try and improve asthma control, reduce our over-reliance on short-acting beta agonist inhalers, so these SABA inhalers. And really that's the central focus of Sentinel, to identify and address SABA over-reliance. So as I was saying there, Sentinel is specifically setting out to try and identify and address SABA over-reliance because we know that that is associated with adverse outcomes for our patients. And we know from the SABINA data and other studies that people with asthma that are using 3 or more SABA inhalers per year, and if we just think about our asthma patients that we look after, actually that's a significant proportion of those patients. And we know that they're at increased risk of asthma attacks, and that the higher that individual SABA use, the greater that associated risk. We also know that over-reliance on SABA inhalers, reliever inhalers, was a prominent feature identified by the Royal College of Physicians back in 2014 when they did the review of preventable asthma deaths. So reducing SABA over-reliance is really important to try and improve outcomes for our patients. And really identifying frequent SABA use can be an early warning sign that someone's asthma may be uncontrolled and that they require review, delivery of good quality, evidence-based asthma care in order to then improve those outcomes. So SABA inhalers are the most frequently prescribed inhalers in England, with over 21 million inhalers prescribed each year, and 94% of those are MDIs. So we've heard about MDIs and the propellant gases, and this slide will demonstrate the carbon impact of MDIs then compared with DPIs. So the top half of this graph being the MDI inhalers, we can see that there is some variation in terms of the carbon impact of those different inhalers. But when we look at it compared to the bottom part, half of this graph, and we can see that the MDIs have significantly higher carbon impact than the dry powder inhalers. So it's pretty clear that addressing our over-reliance on SABA, the most commonly prescribed inhaler, with appropriate use of dry powder inhalers in order to achieve asthma control, has significant potential to reduce the environmental impact of asthma. And that is what the Sentinel project sets out to do, to identify and address SABA over-reliance through implementation of evidence-based asthma treatment guidelines. So by doing so, we aim to firstly improve outcomes for our asthma patients, of whom in Hull and East Yorkshire, where I work, there's around 40,000. And secondly, and as a consequence of improving those outcomes, drive down SABA use and reduce the environmental impact of asthma and its treatment. And I think this point is important, and it's what we believe is so important about Sentinel, as through this project we're highlighting and generating the evidence that delivery of good quality, patient-centred care and the delivery of low carbon care are not mutually exclusive, and we strongly believe that one should lead to the other. So how do we deliver this? Well, one of the key factors that has helped us to address over-reliance on SABA is the appropriate use of maintenance and reliever therapy, or MART, in asthma. So in Hull and East Yorkshire, aligned with national asthma guidelines, our local prescribing guidelines recommend that MART is the preferred regime for people with asthma that require a combined long-acting beta agonist and inhaled corticosteroid inhaler to control their asthma. So for those of you that aren't as familiar with MART, it's when you use the same ICS-LABA combination as both a preventer, so regularly every day, and as a reliever, taking additional inhalations as and when needed for the relief of symptoms. And this can be done because the LABA in MART inhalers, formoterol, is as fast-acting as a SABA, therefore providing rapid relief of symptoms when they occur. The advantage is that when asthmatics experience increased symptoms, suggesting loss of asthma control, when they use their ICS formoterol combination inhaler for relief, they also get additional doses of their ICS, thereby treating the inflammation that is driving their asthma. This approach does not require the use of a SABA and therefore, by default, can tackle SABA over-reliance. Now, we know from numerous trials that MART is associated with a reduced risk of asthma attacks when compared with a fixed-dose preventer plus SABA reliever regime. And therefore, for appropriate patients, MART ticks all the boxes to help us achieve Sentinel's aims. The added benefit is that we also know that over 50% of LABA ICS inhalers prescribed in England are dry powder inhalers, so that all inhalers that can be used for MART are available in dry powder formats. So not only can we improve control and reduce SABA over-reliance, thereby reducing the use of the most commonly prescribed MDI inhalers, we can also reduce the proportion of preventer inhalers that are MDIs. So how can we achieve this? Well, we developed the Sentinel project, and we did this through co-design, which means that we worked with asthma clinicians across different disciplines in both primary, secondary and tertiary care settings, as well as working with asthma patients to develop the Sentinel intervention. And the Sentinel intervention has 5 core components that were designed to raise awareness of the risks associated with SABA over-reliance and to address barriers to implementation and delivery of evidence-based asthma care. So these components are healthcare professional education, implementation of prescribing gold standards that were identified through the co-design process, a programme of asthma reviews targeting those with high SABA use, patient support and education, and then data monitoring and feedback to participating practices so that they can monitor the changes in practice over time. And I'll describe these in a little bit more detail when I come on to talk about Sentinel Plus, which utilises the same core intervention components. But the Sentinel project specifically covers 6 primary care networks in Hull and East Yorkshire and will be subject to robust evaluation in collaboration with Hull York Medical School. And that data that we generate and evaluate as part of the Sentinel project will give us real world data directly exploring the link between improved outcomes and environmental benefit. So over the next couple of slides, I'll show the data from our pilot primary care network and then the cumulative gains that we've observed through the Sentinel project so far. So our pilot PCN has around 30,000 registered patients, of whom around 2,500 have asthma, and then just over 1,000 of those patients have been receiving 6 or more SABA inhalers in the past year. So that's really reflecting a group of individuals at significantly increased risk of asthma exacerbations. And this graph is obtained from open prescribing data. And this shows the proportion of inhaled therapies that are a SABA. So the higher you are on this graph, it reflects high SABA use with low ICS containing inhaler use. The red line is our pilot PCN and the dashed blue line is the national average, with the dotted blue lines being the deciles of PCNs. So as you can see, our pilot PCN had been running along among the top 10% of highest SABA users in the country and prior to the implementation of Sentinel. You can see a dip around about 2019, where it just suddenly drops a bit, and that's an anomaly in the data that's been created by practices merging together, so it doesn't really reflect any genuine change in practice. So what we need to do is just focus on the right-hand side of the graph to see the Sentinel impact. So after November 2020, when we started Sentinel, we see a dramatic reduction in the proportion of inhaled therapies that are SABA. A change that has been sustained for over 12 months now and continues. So that's gone from being in the top 10% or the highest 10% of SABA using practices to being the lowest 30% within the country. Now, I've included this graph to show the proportion of patients within that pilot PCN receiving 6 or more SABAs in the past year. And because of the nature of this measure, there is a bit of a time lag before we start to see the change, but you can clearly see that the proportion of patients receiving 6 or more SABAs has markedly reduced from almost 40% of patients to less than 20% of patients. And we know that people using 6 or more SABAs are at risk of exacerbation, so it's reassuring to see this population shrinking. But this is also a key measure in the primary care contract, which Sarah showed us earlier with regard to those incentives. So there are incentives linked to this metric. So we hope that Sentinel will help practices that take part to meet this target. So we've now completed implementation in 5 primary care networks, and we're just finishing in our 6th and final PCN as part of the Sentinel project. And looking at our pilot data up until October, which is the last time point that we have data available for, and we've seen that around 13,000 fewer SABA inhalers have been prescribed, the vast majority of which SABA with one of the highest carbon footprints. So this equates to an estimated carbon saving of around 350 metric tons, which is equivalent to around 450 transatlantic flights. So alongside this, we've seen an increase in prescribing of inhaled steroid-containing inhalers to the tune of around 3,000 additional inhalers. And that reflects a positive shift in asthma prescribing practice, but still achieves a net reduction in the number of inhalers prescribed of around 10,000. So I saw some mention in the chat about the plastics in inhalers. That's a significant reduction in that, of course. And our carbon saving calculations don't yet take into account the shift we've also observed from MDI predominant prevention inhaler use to DPI dominance, which should lead to a further gain. So as we move on, because of the dramatic and sustained shift that we've seen in prescribing practice related to Sentinel project in Hull and East Riding, we've developed Sentinel Plus, which is a framework then to enable other primary care providers around the country to try and achieve the same. So Sentinel Plus is structured around a website which can be accessed at www.sentinelplus.info. And this website hosts a range of resources to support implementation of those 5 Sentinel intervention components that I discussed earlier. And that includes access to a range of healthcare professional education modules, including how to implement the Sentinel gold standard prescribing practices, information about how to undertake asthma reviews that specifically aim to identify and address SABA overuse, access to patient education resources through a specific patient-facing website with additional resources to help patients understand the need to identify and address SABA overuse and to support MART use where appropriate, and also access and support with data monitoring. And in order to try and support broad access to these resources and potential for GP practices to access support with asthma reviews from third-party providers, we've partnered with AstraZeneca, who will support access to this resource through a donation of goods and services agreement, which can be undertaken at a PCN or federation level. So as part of Sentinel Plus, we've created the Sentinel Treatment Guide that's based on national guidelines and provides additional information about appropriate use of MART. And it has a QR code that links clinicians with the education and other resources contained within the website. And this aims to make it a more interactive experience, recognizing that there's a big difference between having a guideline and actually empowering people to implement that guideline. And that's what Sentinel Plus is really very much geared up to provide. It's the knowledge and materials required to put guideline and recommended practice into practice and therefore drive improvements in asthma care. The Sentinel Plus prescribing gold standards are exactly the same standards that were developed through the co-design process for the Sentinel project. And as key prescribing practices, they were identified as being relevant to both clinicians and patients when addressing SABA over lines. And once again, these are linked via a QR code to the relevant education resources on the website to support their implementation. Now, these gold standards will not be new concepts to most clinicians, but they formally recognise them and put them into a framework, providing the education materials to support their implementation. And we believe that these standards and the implementation of them can really help to drive improved asthma care. And these gold standards include things about adherence to preventer therapies, inhaler technique assessment, focusing on the inflammatory nature of asthma and the need for preventer therapy. So really core elements of asthma care. And the education content within Sentinel Plus comprises a series of live presentations covering core topics related to Sentinel, and we'll be adding more content over time supporting ongoing asthma-related CPD. In recognition that for some patients transitioning to MART can be a big change in how they use their inhalers, we've also created a MART card that can be completed by their clinicians, used for reference about how to use their MART regime and what they should do if they have an asthma attack while using a MART regime. Now, this isn't designed to replace an asthma action plan, but rather to complement its use. We also recognise that clinicians often have limited time to spend with their patients, making it often challenging to undertake that comprehensive assessment, meet all of the QOF criteria, as well as providing the necessary support and education to promote ongoing delivery of that evidence-based asthma care. So we've created a patient-facing webpage that you can direct your patients to with a range of written and video content specifically developed to help patients understand that asthma is a condition characterised by airway inflammation, why SABA overuse can reflect poor asthma control and risk of asthma attacks, and why changes may have been made to their treatment, including an explanation about MART and other asthma treatments for those that go on to them. So in summary, SABA over-reliance is common and is not only bad for patients, but is also bad for the environment. The preliminary data from the Sentinel project suggests that supported guideline implementation and appropriate use of MART can significantly reduce SABA use, and we really look forward to presenting further data as the formal evaluation continues to progress. We strongly believe that it is every clinician's responsibility to identify and address SABA over-reliance, and we've developed Sentinel Plus to help any primary care organisation do the same as we have done with the Sentinel project. So anyone that's interested in Sentinel Plus can go to the website. The link is at the top right hand corner of this slide. And you can express an interest using the Contact Us tab, which is on the right-hand side of that page, and somebody from the Sentinel team will then be able to get back in touch with you. So I shall conclude my presentation there, and thank you very much for listening, and of course happy to take questions at the end of the series of today's talks. So I can now hand over control of the slides to Aarti for the next presentation. Thanks.
Thank you, Michael, and over to you, Aarti.
Hello, everyone. Thanks very much. So my name's Aarti Bansal. I'm a GP. I also work a day a week for Humber Coast and Vale ICS as their Net Zero GP lead. And I'm founder of a network called Greener Practice. We're a group of people working in primary care, hoping to enable general practice to move towards environmentally sustainable healthcare for the benefit of both patients and planet. And I'd like to thank Dr. Alex Wilkinson, who, as many of the slides that I'm using today, come from him. So my key messages are very similar to actually what Sarah and Michael have mentioned, which is that we really have a golden opportunity to improve asthma care and reduce the carbon footprint of care. And in order to do this, clinicians need a framework and easy to use tools to achieve this safely and effectively. And we need to invest in primary care teams to achieve high quality and low carbon asthma care. So we have these two challenges that need addressing at the same time. Firstly, asthma care and outcomes in the UK need improvement. And secondly, as Sarah has mentioned, as part of our responsibility to mitigate climate change, we need to reduce the carbon footprint of inhalers. Now, Sarah mentioned lots of resources, one of which is this hopefully simple to use guide, which has been developed by Greener Practice, but has been through the NHS England Inhalers Working Group, has been endorsed by Asthma UK and the British Lung Foundation. And basically it gives clinicians a framework to start with disease control, think about device choice, and then also consider disposal. So today I'm going to talk about disease control and device choice. I feel Sarah has covered disposal. So with disease control, the first thing is to optimise asthma and COPD care following national guidelines. Now, I'm going to talk about asthma care today. And it's important to remember when we're talking about all of this that we really do need to improve asthma care in the UK. So if you look at the graph, and I've circled the UK, compared to the rest of Europe, we do have quite a high death rate from asthma in the UK. And according to Asthma UK, if you look at the map on the right, actually 3 in 5 people are still not getting basic care. So that means that they're either not receiving an inhaler technique check, or they're not receiving a personalised asthma action plan, or they're not getting an annual review at least once a year. And as Michael and Sarah have mentioned, back in 2014, the National Review of Asthma Deaths said that 2/3 of asthma deaths were preventable. And there were widespread issues with the quality of asthma care. And 2 of those areas included the excessive prescribing of reliever medication and the underprescribing of preventer medication. And those issues are still a problem today. So this slide from Asthma UK, I think, sums up what we really need to happen, which is that we need for asthma patients to be taking their preventer inhaler regularly so that it reduces inflammation in their airways, protects them from the triggers that lead to bronchoconstriction, lead to their asthma symptoms, but also leads to fewer asthma attacks. And you know, there have been many studies now showing the inverse relationship between regular preventer use, regular inhaled corticosteroid use, and your risk from death. So this is the opposite, obviously, opposite to SABA or reliever use. So if our patients had good asthma control, and we say to our patients that we hope that with good control, you're not having daytime symptoms, you're not having nighttime symptoms, you're not having any restriction in your ability to do any kind of activity, then what would that look like in terms of inhalers? Well, we would expect people to be regularly using their preventer inhaler, and that might mean using between 3 and 6 preventer inhalers a year, and not really needing to use their reliever inhaler much at all. So maybe only using up to 2 blue inhalers a year. But if we look at what's actually happening, well, in the UK, 70% of inhalers prescribed are the short-acting beta agonist reliever inhalers, and much smaller proportion of preventer or maintenance inhalers. And actually, of the people who are using more than 3 reliever inhalers a year, which Michael's already said is associated with poorer outcomes, actually that average is over 6. And that's also where most of our emissions are coming from. So basically, that's just repeating the message that we have these opportunities to improve disease control, and that those opportunities really are in lots of different ways. This is me thinking about primary care. So we have that opportunity when patients present to us with symptoms, when they need a repeat medication, when they're coming to us for medication review, annual asthma review, or perhaps, unfortunately, if they've had to go into hospital with an emergency, then these are all opportunities for us to think about how can we improve disease control. And the people who are involved in the processes that make sure that we are doing the best that we can for the patients are the whole team, really. So it's not just one person in the team, but we need a whole team approach to making sure we have the right processes in place to optimize disease control. I'll be talking more about quality improvement in a minute. My slide, oh, here we are. Device choice. So let's talk about device choice now. So the second principle is offering dry powdered inhalers or soft mist inhalers as first choice where clinically appropriate. Now, I've noticed in the chat people are talking about what about children? When we're talking about device choice, we're talking about people 12 and over, and that was respiratory paediatricians coming to a consensus in the UK that they felt that was the cautious and sensible step to take, which is to not recommend this for people under the age of 12. So first of all, at a population level, is there any difference between these two types of devices, the dry powder devices and the metered dose, the pressurized metered dose devices? Well, carefully controlled clinical trials have consistently failed to show any difference in clinical effectiveness between the types of inhalers, and yet real world evidence probably favors dry powdered inhalers. And if we look at country-based data, then we can see the dark green bar here shows that in the UK, we prescribe far more metered dose inhaler than the rest of Europe, and we have some of the worst outcomes. Now, that's not to say that there's a difference in clinical effectiveness between the two different types of inhalers. We can't say that from this data, but what we can hopefully be fairly reassured about is that moving to dry powdered inhalers is highly unlikely at a population level to cause adverse effects. But what about the individual patient? So for the individual patient, it's about, first of all, can they use the inhaler that we're considering offering them? So there are two major differences one major difference that we need to consider between the two different types of inhalers. Now, obviously, inhalers come in a variety of shapes and sizes. There's lots and lots around inhaler technique, more than just how you breathe, how you take them in. But this is an important difference. So this is the one I'm going to focus on. And that is that metered dose inhalers require a slow and steady inhalation, and that dry powdered inhalers require a quick and deep inhalation to actually disperse the medicine into the lungs. So for metered dose inhalers, we're talking about a breath that takes between 3 to 5 seconds at the same time as pressing down on the canister. That can be tricky for some people to coordinate, and so it's often recommended that they're used with spacer devices. But what we do know is that in the real world, spacer device use is low regularly. And some of the metered dose inhalers have dose counters, but not all of them do. So it can be, as Sarah mentioned before, difficult for a patient to know whether they have any medication left, and that can affect both adherence and waste. But they can be good for the young. So as I've said, this guidance is for people who are 12 or over, because we don't know, we can't be sure that young people will be able to generate the inspiratory effort to use a dry powdered inhaler correctly. They might not be useful for people who have severe disease, perhaps the very elderly, and those who maybe are having an attack. But the vast majority of people with asthma probably can use a dry powdered inhaler, and they have the advantage of mostly all of them have a dose counter or ways of tracking your doses, and they don't require a spacer device. And this is just again to repeat the message about the dose counter, that this was a study in Scotland which found that on average 48% of medicine remained unused in returned inhalers. It can be difficult for people to know. Obviously, the other issue is true as well, that in another study, people found that 12% of people were using inhalers that didn't have any medicine left. So that's a huge thing that we can change by giving people inhalers with dose counters. And then, of course, there's the carbon footprint of inhalers. And this was a survey done by Asthma UK at the European Respiratory Society Congress, where 12,000 patients were asked if they would change their inhaler for environmental reasons. And you can see here that the majority of patients either would change it or might consider changing it. And then this is another study which just was looking at what patients' preferences are. Environmental impact was not part of the decision-making process. And you can see that many patients actually just chose to use a dry powdered inhaler for ease of use. But what about patients who need a metered dose inhaler? Perhaps they're stable on it and they feel it's working well for them, or they can't use a dry powdered inhaler. How can we reduce the carbon footprint for these patients? Well, firstly, we can look at is it possible to change the brand of inhaler? So this is very similar to the graph that Michael showed you earlier. Ventolin and Salbol both contain salbutamol. They're both metered dose inhalers, but they have different carbon footprints because of the different volume of propellant used in them. So we can consider switching patients to the same type of device with the same drug in it, and that would lower their carbon footprint. Flutoform and Foster both are combination inhalers with a steroid and a LABA. Some patients might be able to switch from Flutoform to Foster and therefore reducing their carbon footprint. That's just a couple of examples. And then, of course, there's the issue of regime. So if we've got patients who, I'm just going to click all of this on at the same time. So if we've got a patient who's stable, on their preventer inhaler, perhaps they're taking 100 microgram beclomethasone inhaler and they're taking 2 puffs twice a day. We could switch that to a 200 microgram beclomethasone inhaler, but 1 puff twice a day. And actually then they're having half as many inhalers, halving the cost of their prescriptions and halving the carbon footprint. So this one is really a win-win if your patient needs to be on a metered dose inhaler. So I'm just going to talk you through a case example of a patient that I saw a few months ago to try and bring this all together. So this is a female patient in their 30s that I saw a few months ago. She's been diagnosed with asthma since childhood. She actually attended for a skin complaint and then mentioned that she'd been coughing through the night for the last 2 months and it was keeping her and her husband awake. She told me she'd done several COVID tests, they were all negative, and she did notice that sometimes the cough was relieved by taking her blue reliever inhaler and she was needing to use it most days. She found that her symptoms tended to get worse in the winter, but in the summer she was generally symptom-free. And when I asked her, she said she sometimes forgot to use her preventer inhaler. She tended to, if she remembered, use it once a day, and she didn't really tend to use her spacer device with it. And when I looked through her notes, I noticed she was on a low dose of inhaled corticosteroid inhaler, and all her asthma reviews were happening in the summer, and they all suggested she had excellent control, but they were only asking about asthma symptoms in the last 4 weeks. And when you looked at the objective data, she was overusing her reliever and underusing her preventer inhaler. So then examination showed that her peak flow was lower than her best ever recorded. Her chest examination was normal. I asked her to show me her inhaler technique, and she was using a quick and a fast deep breath, which was much more suitable for a dry powdered inhaler than the metered dose inhaler that she was using. And I find that really quite commonly with my patients. So then we talked and I explained that asthma is an inflammatory condition and that actually by taking the regular preventers, she was going to be able to prevent having symptoms and prevent having those attacks. We talked about good control, meaning not having any symptoms, barely needing to use her blue inhaler. We discussed whether or not we should increase her steroid dose, and I offered her a combination inhaler, and I offered her the MART regime that Michael's spoken about. And I suggested she might want to try a dry padded inhaler as it fit with her technique. It had a dose counter and it didn't require a spacer. She decided to go with a combination MART inhaler. I prescribed her a peak flow meter so that she could record what was happening. She could learn how to self-manage her condition, and gave her a personalised asthma action plan. Followed her up in 6 weeks, and there's been a transformation. She's not coughing at night at all. She's actually increased her activity levels. She was sort of self-censoring herself from activity because exercise was causing her to have symptoms, but she's now going to the gym. Her peak flow has improved by approximately 20%, and she hasn't needed to use her reliever inhaler at all. So that's just really bringing the messages together that really, if we're focusing on disease control, we can really improve asthma outcomes, and we can improve the situation for our patients as well. But what I want to talk about now is what we need to do in order to actually make this happen. And I guess my question is, are incentives and guides enough to implement what I'm calling high quality and low carbon asthma care? And I think what we've done today is give some education around carbon footprint, some education around asthma control, and this education needs to happen for everyone to explain why this is important, both for patients' disease control, but also for the wider issue around climate change. But we also need more than that. We need easy to use resources, tools for people to actually deliver this in practice. And we need the system changes to actually make it easy to do it with the clinical systems that we have in place. So one of the things that we've been doing, we're a group of GPs, we've been working with the Health Foundation group. We've also got a pharmacist and a nurse in our group, and we've been using Asthma UK patient groups to help support our resource development, is that we've developed a quality improvement toolkit. And we've divided the projects that people can do into these 4 different areas. We're looking at things, audits that people can do, but also processes that they can improve in daily practice. And those include looking at how can we improve our diagnostic pathways? How can we make sure that we're looking at disease control, offering people devices, and thinking about disposal. And there's going to be educational resources linked into that, but also really step-by-step guides, search tools, for people to actually implement this. Now, this isn't available yet. It's going to be a web-based resource. It will be available on Greener Practice. We will link into all the existing resources that are already out there, whether that be Sentinel Project or Prescribe resources or other resources out there. We're not trying to reinvent the wheel. We just want to make sure that this is as easy as possible for people to do. And just to give you an example of really how step-by-step this is just an example of how on system 1 you can objectively look to see how many inhalers somebody's had. We're going to put SMS invites and email letters that people can choose to use if they want to use them, so they don't have to write their own. We're going to have patient-facing resources that can be linked onto text messages. So there's going to be lots of resources. There's going to be some video resources as well. But I also know that not everybody here is a clinician. Initially, we were told that there are some sustainability leads. There may be respiratory clinical network leads. So for those of you who might be thinking about how we're going to do this at system level, and I know anybody who's involved in writing an ICS green plan will be thinking about how they're going to achieve that 50% reduction in the MDI carbon footprint this decade, then I think when you're thinking about this, my recommendation is you need to think about all of these different areas. So firstly, when you're thinking about education, make sure that you're integrating content and process. So what I mean by that is integrating the clinical update that's required along with the climate change and carbon information that people need, very much like has happened on this webinar today. But also integrate it into process. So all of us in primary care do get updates, clinical updates regularly. We're probably doing respiratory updates once a year. So what's happening in your area? Where are the updates already happening? If there's a programme that's being supported on updating everyone about diagnosis, maybe linked to PHENO, because that's a programme that's happening, or if there's something around inhaler technique training, how can we make sure that those updates are integrated with the broader message about improving care generally across the piece? Secondly, there's no point, as Michael said, producing a resource that nobody knows where it is or where to look for. So making sure that we have an effective way of communicating with teams about how to access the guides and toolkits that are going to make it easy for them to implement this work. But then I don't think that's enough either. I think you can have the guides, you can have the toolkits, you can have the education. You then need to fund clinical leadership time, probably at PCN level, to support implementation. So people need to have the headspace and they need to have a little bit of time to think about how they're going to do this in their patch, what they're going to do first, and support others to implement this. So we really need to think about that. And I know that the children, the CYP bundle talks about having respiratory champions at every PCN level. So we need to integrate all of these different policy documents and make sure we're giving people the time that they need to do this. And then also we need to involve patient groups and medicine optimization teams to make sure that things like the formularies are in line with what we're asking people to do to optimize care and reduce the carbon footprint. Patient groups absolutely need to be involved with messaging as well. So I'm just going to go back to my key messages, which is that this is a golden opportunity to improve asthma care and reduce the carbon footprint of care. We do need to make this as easy as possible, and we need to give people a framework that starts with disease control and then integrates device choice and disposal into that. And we need to invest in primary care teams, which is where asthma is managed the majority of the time, to achieve the high quality and low carbon care that I hope we all want. Thank you.
Thank you, Aarti. That was fascinating.
So should I press the stop presenting button now?
No, I think Josh will take back control and
okay,
everything that's necessary. If I could ask Sarah and Michael to put their cameras on as well. We've got around 15 minutes for Q&A. So if you have additional questions, put them in the chat and we will try and get to them. And there have been a number of questions for various different people. And I think let's start with the one that seems to have been raising a lot of interest in the chat. So this is around DPI and children. So Will, who had to leave us, asked the question around on what evidence are we basing a recommendation to use dry powder in younger age groups? I don't know whether you have views on that. It's as I say, it's certainly engendered quite a lot of discussion in the chat, and you may feel it's already been answered. It was originally a question for you, Aarti, so I don't know if you want to start off.
Okay, yeah, no, I'm fine to start off. I mean, I think it's really hard, isn't it? If you're going to try and get causation data and that clear data, you're going to have to do lots and lots of clinical trials. What are you actually going to look at? I think, again, we can look at the data from other countries who are using dry powdered inhalers much more than we are to be reassured to some degree that, you know, it's likely that people over the age of 12, that's the cautious approach that we've taken in this country, and that's the consensus opinion from the respiratory paediatrician. So, you know, I think that's the message going out there, that we're not 100% sure that dry powdered inhalers are effective in children. It's going to depend on the size of the child. It's, you know, it's going to depend on their lung capacity. That should be an individual clinical decision, as all of these decisions should be taken with the individual patient. And then that's what follow-up is there for. We follow up and we check whether it's good for them. But 12 is a reasonable cutoff, perhaps, when we can probably safely consider that in a patient. I don't know, Michael, if you've got anything else to add.
Yeah, thanks, Aarti. So I'm an adult respiratory physician, so I'm not going to pretend to be an expert in paediatric asthma, and therefore probably not the best person to answer it. Sentinel certainly is targeted at adult asthma. I suppose the key message from my perspective is that what we're trying to do is improve asthma care, and that will improve environmental impact, and the right inhaler is the inhaler that the patient can use. So I think it needs to be individually tailored, doesn't it? But I'm not in the best position to comment about the intricacies of paediatric asthma, I'm afraid.
Indeed. And I don't think Sarah or I would want to either. A question that's come through just now is, should we be encouraging patients to proactively ask their clinicians about the possibility of being switched to a more environmentally friendly inhaler? I like this question because I asked my husband, who has asthma, to ask for a more environmentally friendly inhaler, and the asthma nurse had no idea what he was talking about.
Sorry, Kathy, my sound went slightly then. I'm really sorry, but could you just repeat the beginning part of the question?
Sorry. Should we be encouraging patients to proactively ask their clinicians, GP or hospital-based, about the possibility of being switched to a more environmentally friendly inhaler?
Yeah, this is really interesting. I think Wales are taking that approach where they're doing a lot of patient-facing information to ask, to get the momentum to come from the patients. My personal concern about this is that we've got a lag at the moment. So it may be that patients are starting to come to see their healthcare professionals saying, could I be switched to a more environmentally friendly inhaler? But we haven't done the education and the training and the learning for healthcare professionals. The resources aren't out there yet fully. I know Sentinel Plus has just been launched, but we haven't done a systematic program of education to help update people on that. So I think that's what we need to focus on now, because I think there is a risk now that patients will be turning up to their healthcare professionals and saying, I want to switch, and actually people won't know about this, because generally we tend to just prescribe what we're used to prescribing, and in this country we're used to prescribing metered dose inhalers.
Yes.
I think if I can come in just briefly, I mean, I think there's something to be said, isn't there, around about empowering patients and having patients feeling confident to speak up. And I think part of that, as well as asking for environmentally friendly inhalers where possible, I think we also need patients to understand what they should be expecting from their asthma and their asthma symptoms, because we talk a lot about asthma control, but actually not many people understand what asthma control is. And of course, with asthma control, we're aiming for people to be free of symptoms and not requiring to use their reliever inhalers, because we've got the inflammation under control, and therefore for the vast majority of time are symptom free. So I think that it's not uncommon that patients will come in and you'll ask how they're getting on, and they will say, "Oh, not bad, I'm great actually, yeah, doing really well." How often are you using your blue inhaler? Oh, 3 times a day. Still waking up at night, but they feel like that's okay because they've learned to live with it. So I think there certainly is something about educating patients about what they should be aiming for, that we shouldn't be accepting persistent symptoms, and we should be undertaking best asthma practice really to try and optimize asthma control and reduce symptoms, and then the knock-on effect of that can also be environmental gain.
I couldn't agree more with Michael. I think patients often live with symptoms that could be better controlled, and there's we do need to think about empowering patients to expect more, and in terms of their control.
Thank you. There were some questions, and there's a lot of questions coming through, and I should be quite clear, we're not going to get through them all, but we will do our best to answer them all and put it in writing after the event. So there were some questions around inhaler disposal schemes earlier on. So I wondered whether Sarah, Aarti, Michael, you're aware of any disposal schemes.
So at the moment, there's a few things. So in the past, there have been schemes run by pharma to try and improve recycling of inhalers. Most of them have stopped. There is one remaining at the moment, which is based on envelope, like prepaid envelope, that patients can use to return their inhalers. This is still a pilot, so it's on a limited geographical footprint. In parallel, so that's to explore recycling, and I've seen in the chat a lot of conversation on the difference between recycling, incineration, and this is quite complex. At the moment, the best solution that we can use is to bring to pharmacy, so that pharmacy can send for incineration, which breaks down the propellant and then avoid the harmful emissions. This is not ideal, but this is what we're doing at the moment. We're also working in the background to see at what can be done. First of all, to increase awareness, because at the moment the return rates are really low anyway, but also to find slightly more effective schemes to do a bit more of the recycling bit and not just the incineration. So except if you're in a place where there is a pilot scheme, at the moment the best advice is bring the inhaler back to the pharmacy.
Thank you. So there are some questions for Michael around Sentinel. So the definition of an adult in Sentinel.
Yeah, so Sentinel is predominantly aiming, well, it is aiming for 18 plus. So it's not addressing pediatric asthma. It's not directly addressing the kind of transitioning patients going between pediatric and adult services, and it has been targeting adult asthma. So we recognise that there is a desire and a need to support clinicians looking after all age groups of asthma patients, and we certainly have had discussions around about programs that could be more specifically tailored to pediatric populations, but we haven't got to that yet. So Sentinel is adult asthma only, and we use an 18 cut-off, and that's what will be used for the evaluation.
Thank you. And were there any other efficiencies identified with healthcare resource, particularly in terms of spend?
So that will all be looked at in terms of the overall evaluation within Sentinel. So there's kind of two elements in terms of the data reporting at the moment. The first is publicly available prescribing data, which we all have access to, and we can all look at how we're performing in terms of our prescribing. And we're using that at present to feedback to practices and for the pilot evaluation, which is all very useful. We can also get the EPAC2 prescribing data. What we are doing for the formal evaluation, so the way that the Sentinel project has been rolled out locally is with what we call a step wedge design. So we do one primary care network, then the next, then the next, then the next. And we can then look at what's happening prescribing patterns in those that we haven't got to yet. So we essentially have a control which we can track change. So we know what the intervention's doing specifically rather than just changes overall over time. So the formal evaluation will use primary care data, patient level from the practices, shared with commissioning support units, anonymised, and then evaluated and analysed by the University of Hull. So there's a very robust system to evaluate that data, and that will give us data on things like exacerbations, healthcare resource utilisation, both community exacerbations and hospitalised exacerbations. So we'll be able to track all of that data. We just don't have that yet.
Thank you.
If you invite me back, I'll present that in the future.
Well, yeah, definitely. Can you only access Sentinel if you work with AstraZeneca?
Well, I suppose on the definition of work with, so as you can imagine, this kind of stuff and developing these resources and having a nice website, of course, comes at a cost. So the project has had funding support to develop that. The resource sits within the University of Hull, but is accessible through AstraZeneca through a donation of goods and services agreement. So it's not so much that you're working with or for AstraZeneca, but it is through an agreement with that the resource is funded. And then you can either access all the Sentinel Plus resources yourself, and in some cases you may, again, working with AstraZeneca, if you want to, through an agreement with AstraZeneca, you can have third-party support for asthma reviews in line with it. Thank you.
And then this wasn't phrased as a question, but it's come up a couple of times in the chat around the problem with over-reliance on SABA inhalers being the way that asthma is perceived. So that the comment was, we tell diabetics the risk to their feet if they get neuropathy with uncontrolled diabetes, but we don't stress the risks of fixed airways disease to patients with uncontrolled asthma. We should sell preventer meds in asthma as protection for the lungs. And I wondered whether you agreed, disagreed, saw some issues with this.
Yeah, thanks. Yeah, I mean, I do agree that there is the perception, the way that asthma is perceived, and the reliance on the blue inhaler. You know, you watch any TV program where you've got somebody with asthma or any lung problem in it, and the first thing they do is pull out their blue inhaler and take a puff on it. And we know that adherence with preventer therapies is very poor. And I did see a comment in the chat as the talks were going on about the fact that you get immediate relief from your lever inhaler. So there's this perception then that the blue inhaler is the one that helps. And I think that is a real risk. And certainly the unopposed action of bronchodilators, so beta agonists, is what is the problem. So it's that overuse of the SABA and underuse of inhaled steroid-containing inhalers. And that's where I think guidelines and GINA internationally are shifting towards the ICS LABA combination inhalers or ICS formoterol combination inhalers being a safer way to approach asthma on the basis that when you're getting that relief, you're also getting the steroid. And I suspect that we'll see a shift towards that over time. In terms of Sentinel, we focus on MART for those patients that require an ICS LABA combination inhaler to control their asthma, and those that are suited to that, we suggest MART as the preferred regime for that, because it takes the unopposed short-acting beta agonist out of the equation.
Thank you.
Yeah, I mean, the only thing I would add to that is just agreeing with Michael there that if we give people separate inhalers, then they're likely to use their reliever inhaler when they need it, but they're less likely to use their preventer inhaler all the time, and we kind of know that. So just from an adherence point of view, sometimes a combination inhaler is the way to go. And for some of my patients, that's the reason why I've switched them to MART, is because they can't remember to take their preventer inhaler. Obviously, we should encourage them. We should talk about asthma being an inflammatory disease. In a similar way, I heard one pharmacist talk about eczema. So, you know, a lot of patients might think, oh, steroid makes it better, but actually it's the emollient that's preventing you from getting the flare up. So, yeah, we do need to think about how we talk about asthma.
Thank you. And here's one for you, Aarti, around it. How do we get GPs interested in asthma care? Standard response from many GPs is that nurses do the asthma care and it should be the whole team's responsibility.
Yeah, I agree that it needs to be the whole team. I think one of the, it's kind of, in some ways, it's become a bit of a feature of long-term conditions being seen as part of the annual review QOF template thing. And because our nurses do that chronic disease long-term management, there is a risk, I suppose, that we get a little bit de-skilled because it's the nurses who are seeing the patients regularly. I think we need, that's kind of why I put up that slide about where is the opportunity for quality improvement, because I think when people think about long-term condition care, sometimes they only really think about that annual review, but actually you've got all of these other opportunities with all sorts of other clinicians involved, which will make the difference. And we need to all be working together. We need to have a shared vision of what we're doing, a shared understanding of what we're doing. So we also don't undermine each other. You know, like what you don't want is for a patient to be coming to an annual review, getting some advice maybe from the nurse or getting a medication review from the pharmacist, then having acute symptom control problems, coming to see maybe a GP and having a different message. And I'm not saying, you know, GPs don't know about this, but I think when we look at education, we need to explain why it needs to be a whole team approach, and we need to make sure that the education happens across the whole team. I feel really strongly about that. So yeah, absolutely.
Yeah, and Eula Hampson has mentioned, don't forget the pharmacy team.
Absolutely not. Yeah, pharmacy team are crucial.
Yeah. So I've got one more question that I want to ask for Sarah, which is around the, are there any plans to look at what other countries have in place around inhaler recycling, disposal, recovery schemes that we could look?
Yeah, so we've been looking at this a bit. We haven't come across anything that's, you know, like majorly successful yet. This is part of like this work we've started around, you know, seeing what we can do on a national level for disposal or recycling, depending on what we find. And I've seen also comments in the chat around the fact that this should be done in partnership with pharma companies, and 100% agree. You know, like our national clinical director often used the comparison with other big brands of like coffee or else, which offer the recycling element as part of the product they sell. So we will definitely work with pharma companies on this.
Good, thank you. And then I just wanted to ask Michael and Aarti, any questions in the chat, because I know you've been looking through the chat, that you particularly wanted to answer in the last 4 minutes?
I suppose just to kind of add to Aarti's comment about the whole team, I mean, I completely agree with that it is absolutely crucial that everybody is on board and familiar with good quality asthma care. And I think there's excellent practice across the whole range of clinicians and indeed the non-clinicians who are supporting and involved in the, you know, in the management and supporting the management of asthma patients. What I think we need to do and what we have a responsibility for, I suppose, within secondary care is supporting that. And what we hope to do through development of the education resources and providing additional written and video content and information is to try and support and empower people to feel that they have the knowledge and expertise to continue good practice and to improve practice where we can. And I think one of the things that we've really learned through the Sentinel project in Hull is actually there's a huge amount that we can learn from each other. And I have learned a huge amount from my colleagues in primary care through working with them to develop this project and then to run this project. And I think that shared learning is really, really important. And it makes forums like this really, really important.
Thank you.
Yeah, if I had a final point, over and above the ones that have already been made, I would just make the point that it's really hard out there, isn't it? At the moment, we're all we've all been working really hard through the pandemic, just about getting through the load of patients that are coming in all the time. So we need to find ways to support people with the protected time needed to actually update themselves, but also to implement the work. And I just want to repeat that for all the people who are thinking about their green plans. Don't just put the aspirational guidance out there, really think about implementation and use all of those networks and existing supports that are available to make sure that you're providing a holistic message. Don't provide a broken up message just around diagnosis or just around inhaler technique training. Bring this all together, think about how you can do quality improvement across the board, and really upskill people with the whole message.
Thank you. So I think this has been an absolutely fascinating session. Thank you so much, Aarti, Michael, Sarah. Really, really appreciate your time and your expertise in this space. Thank you to everybody who's attended. The conversation in the chat again has been fascinating to look at and see all the stuff that's been shared and discussions that have been had. I've taken away some points as well, particularly around the NICE guidance. We have regular conversations with NICE, and it would be interesting to see whether they're doing anything on this, and also around the green criteria for right to breathe, which I think is a really interesting point. So thank you all very much. Enjoy the rest of your day. Have a fantastic week. Bye.
Thank you.
Thank you.
Thank you.
Thanks. Bye.